Critical Links, Community Health Workers is a co-production of the Blue Cross and Blue Shield of Minnesota Foundation, looking beyond healthcare today for ideas that create healthier communities tomorrow, and TPT's Minnesota Channel.
What's wonderful about working with community health workers is they really truly seem to have a passion for community health.
They don't just build the bridge, but they link the services together.
I do believe that they help clients to make change. They help clients to understand, again, from that grassroots level.
Any day I'm at work, I always feel needed at work. Always.
It's one big thing, though, and I know
you don't have the desire to help, then you don't have a community.
But you still seasoning your food.
Regardless of where you are from, whether you live in an urban, suburban, or rural setting, and regardless of your ethnicity, we come from many cultures and can all call Minnesota home. People are products of their circumstances and cultures. Just as a particular group may define their relationship to their family or their understanding of education, cultural beliefs and practices play a significant role in the health of individuals and communities. To meet the needs of Minnesota's diverse populations, health and human service organizations are increasingly turning to community health workers. Community health workers offer bridges between cultural communities and the state's healthcare and social service systems. They are typically bicultural and bilingual, and their jobs take them outside of a medical setting and into the communities and homes where their clients live. This program will introduce you to several community health workers. You'll hear about how they make a difference to the community members they serve. You'll learn what their employers have to say about how they improve health in cost-effective ways. And you'll find out how they can train for their unique bridging role and, at the same time, build a health career pathway here in Minnesota.
A community health worker is a bilingual, bicultural individual who's trained by our agency as well as through the MNSCU system to link clients who have barriers to receiving health or social services.
They really have a true passion and a true a belief in working with their communities. So it's really just a fantastic group of people to work with. And I think that is what makes them unique. It's really more than a job.
It's a connection. The clients are so disconnected with the medical world.
A year ago, we probably would not have had someone from the community walk in and ask for a community health worker. We now have the community walking in saying, can the community health worker check my blood pressure?
People here know me, and they know me as the blood pressure lady, because I don't care where I am, I'll take your blood pressure, especially if something to my eye looks like it could be wrong.
I can get your blood pressure checked.
I have never had a problem with recognizing something and not having a person want help for it. A lot of the problem in the community is people just don't know. They're not aware of what's going on. So usually they're very receptive to anything that I'm advising them on.
I work with her brother at the candy store and the dry cleaners, and she noticed that I had a health problem. I feel great.
Good. Glad to hear that.
She's going to advise me on different programs, weight programs and exercise programs that I can go through, keep my weight down, and she's going to advise me through that, and she's going to work with me, you know. She's a pretty good teacher, really, actually, you know, because it helped me out a whole lot. I wouldn't have lost over 200-something pounds if it wasn't for her.
I'm going to teach you how to do your blood sugar testing. Okay, now this is all the tools.
We received funding to develop a curriculum, and we wanted to take it one step further than that. Before you put a new curriculum out there, you have to have a workforce need. There's been a lot of studies that have shown that, especially in certain fields of healthcare, such as nurses, dentists, pharmacists, that there'll be a large shortage in the workforce to meet the needs of the people in Minnesota as it relates to healthcare. And so we developed a curriculum which we see as a stepping stone or a pathway into higher levels of health care.
And we'll get the
We also see this curriculum as then a way for these diverse students, once they get their foot in the door and they receive a certificate and they start working in the healthcare field, that they might be interested in continuing their education into higher levels. So we see this as a way to help diversify the healthcare workforce. And so we then developed what we called a policy council. So it's a partnership, collaboration of many different organizations statewide. It's healthcare payers, healthcare industry, post-secondary school, private and public organizations like Minnesota Department of Health, Department of Human Services, many nonprofit organizations. Anybody who is interested comes to the table. And the reason that the statewide Community Health Worker Project was able to move at the speed that it moved, in 3 years, we developed a curriculum, implemented the curriculum in 5 schools, have graduated over 144 community health workers, developed a workforce role, created 42 new positions throughout the state, and passed a bill for reimbursement, which has never been done nationally, is outstanding. And it's because of the work of this partnership. And they all believe in the role of the community health worker. And I think because of that belief, they're the link between our policy council and their organization.
The community health workers were well trained through the Minnesota State curriculum on how to handle sensitive information. And so as an employer, when I go out and I network with individuals and tell them about the program, especially in our local community with healthcare providers, they are very concerned about privacy because they're still seen as bilingual members of both communities. And so, you know, these communities, the ethnic communities can be a little small. It can be very easy to see how an outsider may think that those lines are being blurred, but because of their training, they are very clear on their roles, and I can speak with confidence about their level of training and reassure potential partners about the professionalism that we observe.
I see the community health worker as being a liaison to the patient, really. They come in at a level that's more where the patients are at.
I need medical refill, please. Mìnhប្រាប់លេខគេទៅ delivery please. អាហ្នឹងគេយកមកជូនដល់មីងដល់ផ្ទះនឹងមីងណា
We have patients that have needs that we're not meeting. So then, you know, our traditional thing was, well, we just kind of tell patients they got to get in more or do something like that, and that doesn't always work. Whereas if someone from the community or someone that is more like them, that explains to them in a way they perhaps understand, in a more motivating way, that we can accomplish some of those things.
Please.
Delivery please.
Delivery, please.
Okay.
To learn the terms and learn the communication and learn how to prevent and help other people and their family and spread the word. It's called building community capacity. So the more people in the community learn, the healthier the community is going to get, and the better it's going to thrive, and it's better for everybody all involved.
Community health for me really is just a way to not only connect to my community just personally, but really to be able to give back to my community.
waxaan ku jecelahay community-ga inaan u shaqeeyo. Community-gaan u shaqeeyo waa Somali community weeyaan, waa dadkaygii weeyaan, aan aqaanay afkooda, aan aqaanay dhaqankooda. Sidaa darteed u shaqeyntaan u shaqeynaya waxay ii tahay iisiba ii tahay way ii dhib yar tahay.
And a big part of that comes from that I'm in the community. I see these people, I let them know that if you want to go see the doctor, come see me, I'll go over with you.
You been taking your medication?
Always.
All right.
5 o'clock every morning, like clockwork.
I've been working with Latricia on exercising and different other exercising programs. We started out walking 2 miles every Saturday. Now we done moved it up into 3 miles. I was originally weighing 300 pounds, and now I've came down to 283 by working with Latricia. She keeps me motivated. She calls me and makes sure I'm staying up on my toes.
I know I called your house and your daughter told me, my mom can't talk to you right now. She's on the treadmill, Latricia.
I'm glad I met a person like Latricia, because before I met Latricia, my self-esteem had got real low.
Frederick was referred to me from the diabetes nurse, and for his blood pressure and for his weight. His blood pressure has been lowered tremendously. He came in to see me the most recent visit. His blood pressure is in order now. It's where it should be. He's losing weight at the pace he should be, and he's very involved with his health now.
How many miles a day you doing, Frederick?
Do 14 miles a day.
He's more than happy to work out. He's always looking for things to do. He's a goal that I set is for the patients to do 10,000 steps a day. Frederick is doing 25,000 steps a day. So that is amazing. He went from doing 300 steps to 25,000 steps. And he has no problem showing me his pedometer that proves how many steps he's doing.
Yeah, I do too.
He's just always trying, always eager.
You probably don't even go to sleep.
I like to see all of my people to be healthy and to be succeed in their lifestyle. And everybody have a happy face. That's what I think about.
Sheena was the first Cambodian, she and her husband, the first Cambodian family to arrive to Rochester. And she and her husband have taken it upon themselves to recognize all of the barriers they faced when they first arrived and are very active in ensuring that the new arrivals don't face those same barriers.
2, 1, 3 ហើយទៅឡើងនេះថាហើយទៅគេថាអូហើយទៅមិញថា thank you delivery please 27 years ago when I came I feel lonely. Then I feel some elderly stay home and lonely. Sometimes I spend time and they call, are you okay? And they say, oh yeah, come to see me, I come. And to be companion with them, talk with them to make them release. That's one of my jobs that I like, to be with my community close, to make them feel happy. When they're happy, they're healthy.
One story that comes to mind is of a Cambodian client who called her community health worker at 6:30 in the morning on a day and said, something's not right, I just don't feel right. And the community health worker is not trained to provide a diagnosis. She understood the scope of her work and instead immediately conducted a three-way phone call with the nurses line at the St. Mary's Hospital. And the nurse asked them basic questions, and Sheena tried to provide encouragement to the client and said, it's okay for you to answer. This is very important that we go through this process to make sure that you get an answer as far as what could be so wrong today. And it turned out the client was having a stroke and was able to get an ambulance and get to the ER and had a full recovery. And later we received notification from St. Mary's that that wouldn't have happened had the client even waited an additional hour. And it's just one of the many stories that we have that show how community health workers connect clients to services. According to our last client survey, the #1 barrier is language and the second barrier is transportation. However, other clients also face barriers in terms of culture and their belief system being very different from that of our mainstream Western healthcare system. And others also face barriers in terms of insurance status or low health literacy.
I think the challenges and the barriers are the same as what any other community member would experience. They find that it's lack of education, a lack of knowledge of the services that are available to the clients, and again, how to navigate the healthcare system and utilize it in a manner that can improve their health.
There's barriers sometimes with literacy and just with the trust issues. So I know the first couple of years we were working, we really tried to first gain the trust, and I think just through the high quality staff that we trained, and we really did a lot of background research as far as getting the right people into the right positions. But I think just it's a very oral community, the Somali community is, and so you really have to do some high quality work, or else it would very quickly spread in the community that you're not doing that. So we really tried to find some very high quality people that had that background that could be trusted.
Well, I think we're realizing that in taking care of patients well, that the traditional one-to-one doctor-to-patient relationship doesn't always give us what we need. We don't always have the best outcomes. And when we look around at best practices, that I think more of a team model of care is a better practice. And I see the community health workers as a member of that team. So there's often a community health worker, there's a physician or a healthcare provider, the patient is part of that team. There is a nurse often, there's a medical assistant, there is perhaps a behavioralist, social worker. And I think when we develop these interdisciplinary and comprehensive teams, I think we are able to better serve the needs of the patients.
I think to have that, that culture-sensitive ear is important, and I think we feel that position for a lot of doctors and nurses. I mean, they're so bombarded with their own work that it's hard for them to really sit down with somebody who English is not their first language, who really cannot tell them how they feel. You spend 15, 20 minutes with your doctors and nurses. I mean, there's so much that they can do with you in that really small amount of time. But with community health workers, there is these relationships that we build with people, and they allow us to really go beyond, just that, patient, doctor, patient, nurse, relationship. I work mainly with young Somali kids, high school students, and we did this play on HIV/AIDS. It was sort of like a drama, and for me, I think the biggest help or the biggest way that we've supported them was to really give them an avenue to talk about issues that are really stigmatized in our community, I think they see me as somebody that they can come to and talk to because I am relatively, around their age. But at the same time, they feel as though I have a knowledge about some things more than they do, I think the best way that I help these young kids is really be that ear and that, sense of support for them that they don't get from home, because a lot of their parents really don't know what they're going through. A lot of their parents never went to school in America. They don't know, whether, peer pressures and health issues that go on in their daily lives.
Our community health workers are really focused on eliminating health disparities and closing that gap. And one of their strategies is to ensure that every one of their clients has a primary care home. 98% of our clients feel supported and connected as a result of having a community health worker in their life.
They're trusted community members. They know the culture, they know the language. They have some health background that they get through training through an agency or through the community health worker curriculum course. They're really that first point of contact often. And I think especially what's sort of unique in Minnesota is there's a large refugee and immigrant community. And so unlike some other states, we really have a much more diverse workforce now. And so I think it's becoming more and more important to really make those links and to serve as that bridging agent between the health system and the communities.
They're leaders. They're ingenious in the way that they help motivate people. They're very passionate.
They're also able to educate the client on how, again, to navigate the system, how to make that appointment, how to get transportation if transportation is needed. And the other thing is that they're able to identify risk or barriers that may be in the client's way by talking to the client and building that relationship.
People always say, well, what makes a community health worker different than a social worker, a public health nurse, or a CNA? And really when it comes down to it, it's the ability that they have of trust that they can develop within the communities and with the providers. But the trust for a community health worker going into community and opening those doors for services is huge. It's huge. And I think that's probably the biggest thing they bring. We were approached by a woman who's deaf and said, I want to be the first national deaf community health worker.
Meetings from various times, someone should.
Well, my feelings being a CHW, really something I should have done a long time ago. The response that I actually got from the medical community is that they're saying that the interpreters are not enough. It doesn't actually solve their problems. It doesn't help their health or comprehending everything all through this particular individual. So I wanted to bring health professionals in and get the facts and outline those facts to help deaf individuals to say, oh, my situation is slightly different from theirs. We had a family that would go to the emergency room a lot, and it was a frequent thing that this family would experience. Anyways, this social worker gave me a call and said, this family comes all the time to the emergency room, and we're not really, don't know what to do, because these really aren't emergency type things. It's like colds or sore throats. So I was able to meet with the family and explain and ask questions, and they're just like, no, we use the hospital emergency room for these particular reasons. And they were satisfied with the services that the hospital was providing. The reason why they liked it is because that hospital, or that particular hospital, provides interpreting services. So it was basically, we helped her find a clinic, we found her services that she needs, and now she's very successful. And I said, remember, the emergency room, you know, use this for emergency purposes, not for day-to-day, you know, non-emergency type things.
We're seeing all these different pockets of what we call communities that not necessarily from different countries, but within our own communities that need services.
Poor people of our country don't come into health care until they absolutely cannot not go in. And if they were to learn prevention, they would not have to get to that degree. Prevention is the key to decreasing the billions and billions of dollars that this country spends on health care for the people who are uninsured.
I'm going to take, for example, North Point Health and Wellness Center in Minneapolis. They have a great system of the way that they support their community health workers. And because their community health workers are in not only this organization, but in those organizations within the community, it opens the door for those diverse and underserved populations to come and receive services. So that continuum of care is provided, because if a CHW, if a client comes to a CHW here at IMMA and they link them up with the family physician, okay, they've established that first step. And they can do that with, 5 minutes, where a new family or underserved population, it might take them months to be able to do that. And by that time, what could have been detected as an early disease and manageable now has become a chronic disease and unmanageable. So it creates not only that continuum of care, but the management of that care. And the idea is, if a mother who's pregnant seeks early care, then the disparity as it relates to healthy babies is going to make, or baby mortality, the mortality rate is going to change. So that encompasses then the building of capacity of a community, an individual, a family, and our healthcare system.
I think that what we're realizing and what we're really trying to do here is being a comprehensive, continuous medical home for folks, for patients. And I think that's been shown in studies that that's cost effective. There are some places that have developed these teams, and they've decreased hospitalization rates, they've decreased ER rates, they actually decreased clinic visit rates, and improve health outcomes.
If you're in the healthcare world, the bottom line is cost. And so in order to create this is typically, or really realistically, it's a new position. So in order for a new position to really be created and to be accepted, you have to show what value they bring. And in the case of the community health worker, what we can put our finger on and show you lots of reports on the outcomes of a community health worker, it's the hospitals and the clinics and the payers need to see that bottom line number.
I see community health workers as an integral part of the healthcare workforce. I see community health workers being utilized in health and social services, in clinic settings, as well as in community-based organizations. I can see community health workers teaching cultural competency classes for providers, being involved in some policy work to ensure that clients and providers are providing the highest quality of care, that we're saving money in our healthcare system by doing it right.
And so we have to figure out different systems of care that will meet the needs of the community.
I really hope that we can broaden our appeal and to continue working both with the policy group as well as maintain the community health worker peer network so that policy is moving forward in legislation and making sure that in the state of Minnesota, community health workers are well supported, as well as at the community level, making sure that there's responsive programs that are being implemented that really address the felt needs of the community.
Okay, hi,
I need.
I would like to see them be a real important part of this healthcare team, so that if you have an issue, say you're a patient and you wanted to call, and you could talk to either your doctor, your community health worker, your nurse, your medical assistant, your behavioralist, all of whom would know you, and they say, okay, yeah, sure, let's talk about that. And there's different roles for everyone.
Working here in Minnesota on health disparities, I think there's so much work that needs to be done, and if you can really use the community health workers and get close to the community, I think a lot of, not all problems, but a lot of problems will be solved by really having the community learn more about the health system, but also I think health providers will really learn a lot from the communities.
I really see the community health worker being a part of the clinical team in a way that they have never had that before in a healthcare setting, in a clinical setting.
So we really see it as a very important role in ensuring the quality of care that clients are receiving, but also to improve the understanding on both sides of the patient and the provider.
I think if we have a team approach to that, patients have better odds at access and they have better odds at getting what they want and what they need.
Well, you know, I'm living proof.
Critical Links, Community Health Workers, is a co-production of the Blue Cross and Blue Shield of Minnesota Foundation, looking beyond healthcare today for ideas that create healthier communities tomorrow, and TPT's Minnesota Channel.